Can you hear me better now? Okay. Well, hello and welcome to the 9th Annual Integrative Medicine Day. Thank you all guys all so much for coming. We have an awesome event planned for you. To provide some background, the Student Alliance for Integrative Medicine is a student-governed organization in Portland, Oregon, comprised of students from the National University of Natural Medicine, the Oregon College of Oriental Medicine, Oregon Health and Science University, and Pacific University, and the University of Western States. We are an affiliate of the Oregon Collaborative of Integrative Medicine, and we are comprised of all OCIM institutions. The mission of SAME is to foster collaboration among students in the aforementioned institutions in order to deepen awareness of the contributions of all medical professions for the purpose of promoting health and optimizing patient care. It is the vision of SAME to be on the forefront of the future of healthcare by integrating practice and communication between the healthcare professional students across the healthcare continuum. Furthermore, SAME aims to increase student understanding of the strengths and contributions of all health professions to cultivate a culture of patient-centered healing and care. In line with this mission, we put on this event, Integrative Medicine Day, every year, a half-day conference where top professionals in their field discuss various health topics in the world of health. Before we dive in, I want to thank a few people. This event takes a lot to put on, and there are a lot of students involved in the planning, organization, and execution. Please stand if you are on our executive board for SAME, or at least come to most of the meetings. Some of them are outside, but so we have one here, one here, one here. If we can all just give them a round of applause. They've been super awesome in helping us out. I also want to send a huge thank you to our sponsors, Priority One, Pacific Foods, Pure Encapsulations, Metabolic Maintenance, the CHP Group, and all of our participating institutions. This event would not be possible without them. I would also like to thank our speakers who so graciously have donated their time, and all of the amazing people along the way who I'm not going to necessarily name by name, but have helped make this event hugely successful. I just realized I forgot to introduce myself. My name is Marissa Sosky. I'm the president of SAME, and I am a student at NUNM, currently in my 4th of 5 years. So if you have any questions, please feel free to find me at any point during the event, during the social, anything, if you have any questions about SAME or NUNM. Just some housekeeping things. We will be keeping the front doors closed during the panel event, during the speaking event, so you can, but there are doors in the back, so feel free to use the doors in the back. You can find a schedule of events on the program. Also, it's been posted outside in various locations. Bathrooms can be found just outside the lecture hall, both on the top and bottom floors, and then behind the stairs, too, over by registration. We're having a raffle with some amazing prizes, and the raffle prizes are the raffle is being held outside by the registration desk. Please, if you can, support us. All the money just goes pretty much to putting on this event and helping us meet our costs for that. We are also, for the first time, selling T-shirts. We have our own it's exciting. I know you guys probably aren't excited as we are, but we have some pretty cool T-shirts for sale too. That's just another fundraiser. So if you can, help us, if you're interested, get a T-shirt. Without further ado, I'll bring up Rebecca Wilkes, who's going to moderate our first panel.
All right. Can you hear me? All right. Can you hear me now? Kidding. Okay. My name is Rebecca Wilkes. I'm a chiropractic student at the University of Western States, and it's my pleasure to introduce the first panel. This panel is Integrative Medicine Clinics and the Benefits and Challenges. And so just to rehash what Marissa said, I want to remind you that we do have a lot of things going on in between these panels, so just feel free to go outside, look at the raffle, things like that. And but in these panels, the way that they're going to be structured are that there are 2 minutes per question per panelist. After each panelist has answered the question that we pose, they will have a moment to be able to discuss. After that, we'll move on to the next question. But as you have questions yourself through this panel, you have note cards on your desk. You should pass them towards the center. A lot of those same reps that you saw, if you could just pass them over towards that way, they will be able to give me the note cards, and I can ask some of your questions as we go through the panel. So basically, today we have Dr. Chandler, Dr. Mauer, Dr. McNally, and Dr. Moonshine here. And if you wouldn't mind, if you could just introduce yourself, give a brief explanation of where you are, where you come from, where your degree is, and then we'll get started. So start with Dr. Chandler.
All right. Good afternoon. I was a 2001 graduate from NUNM, or NCNM as it was when I was there, and then started to work for Providence after a residency with Dr. Dixon Tom, and in 2004 I started with Providence Hospital, became manager, went back for my MPA, HA, then became medical director, and have helped grow the program from 3 naturopaths to now there's 7 or 6 of us, 5 of us are acupuncturists, 3 massage therapists, and a chiropractor.
Hello, my name is Kim Mauer. I did a residency in anesthesiology and 2 pain fellowships in pain management and pain research. And I'm the medical director of the OHSU Comprehensive Pain Center, which now has 2 chiropractors, 1 dietitian, 2 rolfers, 3 acupuncturists, 1 yoga instructor, 5 mindfulness, 4 pain psychologists, what else am I forgetting? 4 massage therapists, physical therapy, and I think that's everything. I might be forgetting something, but I think that's everything. And a naturopath. And that's my story.
Hi, my name is Jeff McNally. I went to chiropractic school at Life University in Atlanta. I moved out here after working in a clinic in Atlanta, which was, it's an integrative neurology clinic where we had chiropractors, and then we also had a neurosurgeon that was the clinic director. So interesting combo. And then out here, it's just chiropractors right now, but we all have our diplomate, which is a postdoctorate degree in clinical neurology. So we do a lot of concussion, brain injury rehab. And then we also are moving and in the process of hiring a psych NP and a naturopath afterwards. So if anybody's graduating soon, let me know.
I'm Kathy Moonshine, and I'm a clinical psychologist, and I oversee Pacific Psychology and Comprehensive Health Clinic, which is a training clinic for the School of Graduate Psychology at Pacific University, and graduate psychology is housed within the College of Health Professions. So we have 10 sister professions, and I think in 14-15 we started a partnership with NUNM, and so we currently have 5 NUNM primary care shifts within our mental health clinics, and then in addition to that on the team we have occupational therapists, speech language therapists, at times we've had physical therapists and also pharmacists with us, and so we're doing integrated and integrative care in that process, and we do a whole variety of interventions and collaborations between providers.
Sounds like we have a good lineup today. Let's start with the first question. So we'll start with Dr. Chandler. What, in your opinion, would define a medical clinic as integrative?
So to me, an integrative medical clinic could be conventional and or non-conventional. And so for us, most of our practitioners, as you heard me describe, are non-conventional practitioners. So conventional would be MD, DO. And so I think the other aspect would be to have that combination of the conventional, non-conventional within your own department. We just, as an integrative center, will often partner with those conventional practitioners outside of our clinic. But within our clinic ourselves, we just have NDs, LMTs, acupuncturists, DCs.
So when we looked at this definition, we kind of went through the whole rigmarole, and we were like, there's complementary alternative medicine, there's integrative. And at the end of the day, we kind of decided that for us, the definition of integrative medicine clinic just doesn't really matter who's in there, right, and what their title, but that we're all working together, and that it's patient-centric, that the patient's in the middle. So we're all just mixed together, and we have 80 of us, and no one really knows even all of our titles, and everyone goes by first names, and we don't really worry about what the definition of integrative means, but look at it as providing care for the patient from multi-aspects of care. And we kind of define it as multimodal or multidisciplinary care. So that's what we did. I'm trying to give you that, and you have your own.
That's
Sorry.
Okay.
And post-call.
So I think, I mean, the general reason for any clinic, whether it be traditional or alternative or integrative, is health. And I mean, the general definition of health is the absence of disease or infirmary. But I think most of us can agree that there's a lot more to it. And that's, you know, a full balance of social, physical, and mental well-being. Now, I think what makes an integrative clinic such is that you have interdisciplinary approach, but also looking at the body at a whole system and not independent systems. So I think we don't achieve health by looking at the body as a mechanistic system. So for example, if I work on one system, whether it be the respiratory system, the digestive system, there's always going to be consequences in other systems, whether that be physical rehab, medication, anything like that. You can always be affecting other systems in the body.
So I think about integrated care and integrative care. And in psychology and maybe conventional medicine, there's been a big push in the last 10 years or so around integrated care, where traditional Western primary care is integrating in mental health and psychotherapy and psychiatric interventions. There's value in that, and there's many programs that are doing that. I think integrative care goes a step further in that it is thinking holistically. It is bringing in, for the patients that are interested in it, natural options, complementary alternative options. It may be bringing in spiritual practice. It may be bringing in things like yoga therapy that may not be considered evidence-based in a conventional model. So I think that in the professional world, there's a distinction between those two, although the terms tend to get used unknowingly, right? So someone may mean integrative when they say integrated. And so I always ask the question, what do you mean by that? Are you talking about a holistic health and wellness framework? Are you looking at alternatives to prescription meds as an option for the health and wellness? I consider that more integrative, and integrated is more sort of conventional synthesis of professionals working together that may not be thinking in that broader wellness sense.
All right. Well, moving on to the next question, we'll start with Dr. Mauer this time. So we'll circulate a little bit differently every time. Next question is, what are some benefits of running an integrative medical clinic, and what are some of its challenges?
Okay, well, this is an easy one because I've been living this. So we started building an integrative clinic 2 years ago. So the benefits are we're seeing our patients get much better. And in my world, where opioids are going away, because you've all heard of the opioid epidemic and the opioid crisis, and epidural steroids are going away, right, for central canal stenosis, for low back pain and neck pain, we were kind of like, what are we going to do for patients? And so we started looking outside the box, and we said we have all these other things we can do, right? And conventional medicine does look a lot at evidence-based practice. But if you really closely look at evidence-based practice, sometimes evidence-based practice doesn't actually have a lot of evidence behind it, right? Studies are all dependent on who does them, and sometimes, sadly, what pharmaceutical or big company is funding them. So we stretched out and kind of started adding all kinds of different dimensions of care, and now we're doing research on it, and we're actually finding really good evidence that our patients who are involved in our naturopathic, Rolfing, massage, acupuncture, yoga classes, mindfulness classes, biofeedback, CPT, are doing better than our patients who aren't doing those things. And we're partnering with Duke to develop a worldwide model to how to develop these kind of clinics in academic medicine. Because we're one of the first academic centers to take all of these groups and faculty appoint everyone. So everyone at OHSU in our clinic has a faculty appointment and goes through a promotion pathway, whether you're a massage therapist or an MD or an APP or an NP or a physical therapist or a Rolfer. So it's been really beneficial for the patients. So that's been the beauty of it. The difficult part has been getting space. As you know, this hospital's on a hill, and the hill can only hold so many buildings before the hill doesn't hold more buildings. So space is a premium. And then it's been a little interesting going through the credentialing process, because when I took our first massage therapist to the OHSU Foundation Board, and I said, we need to license them as instructors, they were like, okay. And they didn't they didn't know how to do it. And then when we had to change the credentialing to get a naturopath on board as a medical doctor, there was all these weird criteria because the medical board didn't really understand the process of naturopathic medicine. So we're trying to open the doors, and that's been some of our hurdles. And then, of course, with insurance panels, it hasn't been hard to get the coverage, but it's been hard to have the insurance recognize that in my visit, included in that billing code, I'm going to have them also see a massage therapist, and then they're going to go to acupuncture, and then they're going to get Rolfed, and then they're going to go get CBT, and then they're going to go get some mindfulness training, and then they're going to go to yoga class. And so we really tried to open the door with the insurance panels, and the benefit of being at OHSU is, as you know, OHSU is on almost every insurance panel there is, being a tertiary hospital. So that's helped us open the door for a lot of smaller clinics to be able to kind of, insurance is seeing the trend we're trying to set. So it's been helpful. And we're partnering with Duke now. Duke is kind of the leader on the East Coast developing integrative medicine in academic centers. And so that's been helpful too, to have a partner in academic medicine to help us develop this.
So I think the biggest benefit is patient convenience. I mean, even with me at like our clinic, I mean, we're working on so much with our patients, but it's amazing, and in a bad way, how many patients are like telling us constantly like, oh, I have another appointment here, another appointment here, another appointment here, this day, that day, this day. And it's exhausting just to hear this stuff, right? So I think having an integrative clinic is awesome, just because you can, you know, cover more stones with one trip, right? So it just makes it a lot easier for the patient, and obviously outcomes are improved as well. I would say a negative is some bravados and egos involved when you have multiple specialties and doctors of different types. I mean, like, who wants to sit in school for 8+ years to not be the boss, right? So sometimes it takes a little bit of humbling of yourself to be able to sit back and just realize that maybe not one person is in charge, and maybe not one person has all the answers. But I think it's really not that hard to sit back and realize that when you see the patient outcomes from combining so many different disciplines together. So I would say that's the negative. But
so I want to start with what's been hard in our systems change over the last 3 years is that we have had a lot of turf battles and overlapping scope, and people having a hard time understanding that and not always wanting to play well together in the sandbox. And we sort of have two levels. We have the existing licensed supervisors, like myself, who may have been trained 20, 30 years ago, long before we were doing any collaboration, long before integrative medicine was really in the mainstream. And then we have all of our health professions that are in our clinic are students training and are doing the cutting art stuff that you guys are doing. And so you guys are being trained in a very different paradigm than many of the existing providers, depending on how long they've been in the field. And so we've had a huge problem with some of our faculty saying, naturopathic medicine isn't evidence-based, and we present evidence to them. They say, well, that's not good enough. And then I hear them say, oh, what I'm doing is evidence-based. And I'm like, yeah, but you have no research either, right? So we have a lot of egos. There's a lot of bias. I have to say that before we integrated NUNM at our clinic, I had all of the bias about naturopaths being woo-woo and not doing normal stuff and weird things. And then I read the political climate of the university, and I said, okay, maybe I should check this out. And what it came down to was building relationships with the providers, right? As I got to know our naturopaths and our other providers, I said, oh, I understand what you're doing. That makes sense. That's good thinking. So the collaboration has really made a difference in our practices in terms of reducing my burnout, feeling like I have more of a team to work on. We just had a violent crisis happen at the clinic, and we all worked together to deal with that. And then I'd love to tell this story about traditionally in conventional medicine and in conventional psychology, we have been very siloed, and we don't talk about what we do, and we don't collaborate. We haven't collaborated with other providers. We had a case in our clinic of a couple coming in for a middle-aged couple coming in for marital therapy, and one of their big complaints is they weren't having sex often enough or hardly at all. We had done therapy with them for a while, and it wasn't getting better. And we started to ask the question in an interprofessional team meeting, and the naturopaths got involved, and the physical therapist consulted, and the occupational therapist came in and did an evaluation. And it turned out that the husband in the couple had a pinched nerve that was preventing him from having erections. We could have done couples therapy for 20 years and never solved that problem. So when we get in our siloed mindset, I feel way more responsible, and also like I don't have all the answers, of course, and our patients suffer because of that. So it was great that we had that opportunity, and then as soon as that was started to be resolved through them seeing all three of the other providers, we worked on very different things in the psychotherapy part of it. We also had another patient that was post-stroke that we had all of our providers working on, and it was very there was a lot of energy that came out of it. We were all refreshed by it, and the patient got much better than if he had been doing all of those appointments all over town.
All right. So I think one of the benefits, as my dad and I have always talked about, my dad's an oncologist at Kaiser, is roundtable medicine. And so at that round table is everybody that person, that patient wants on their healthcare team. You know, whether it's MD, DO, DC, ND, LMT, you know, whoever. And I joke about some of my patients will put their hairstylist on there because they learn a lot from them. You know, how many have come in and said, my hairstylist told me this, and it actually helped? It's like, because they get to talk with a lot of people. And so I think the roundtable medicine is really a benefit because the patient wins, and each person is doing their specialty. And as you've heard, there is the occasion where people's egos can get in the way. And so if we step back from our egos and say, hey, you know, from this perspective, this is what I'd recommend, and then somebody else would have their input. And so there's tremendous benefit when we acknowledge that nobody has all the answers. My dad will, you know, he has said, you know, I don't have all the answers. I admit I don't have all the answers, but hopefully when we're working together that we're doing better for the patient. And when we add more people to the team, it's only going to get better than that. And so when we talk about the impact, I think we're seeing some of the impact with regards to cost savings, patient satisfaction, and that's driving change. So when we can start tying in cost savings and patient satisfaction, some of the triple aim of what we talk about in healthcare, that then we'll start seeing insurance companies cover it more and more. And what we've tried to do too, as Dr. McNally said, is under one roof, sort of that Fred Meyer theory of having everything under one roof. It really helps with compliance. So people don't have to go from building A to another community to get another treatment. And so it's really that mindset of healthcare economics. If we can help the patient be successful and be compliant, we're more likely to get them where they want to go faster. Some of the challenges have also been talked about. It's like we have and still do deal with attitudes. You know, there was a ground rounds that we gave once, and one of the questions that we got from the audience was, why are you even here? Why are we spending money on you? You can imagine that we just gave a ground rounds to medical professionals, and we get that question. And so there are often statements made in ignorance and sort of feeling affronted, but when you look at the data and you find out, wow, there is some benefit to doing these things for this rationale. And so we do see that, and when we get more and more of that, it's just the tide is turning. So when I graduated in 01, where we are now is completely different, and where we'll be in 5 years, 10 years, 15 years is going to be very different from where we are now. So another challenge is space. We have outgrown our space, and it's just trying to, how do we get bigger? It's like, so you typically grow organically. We started in a 3 sort of treatment room with a cloffice and a waiting area that could only sit about 3 people. And now we have an area with 7 treatment rooms and offices, but we still need more space. And so that's one of the challenges that we're finding too, and also finding the right people. Who is going to be a best fit for this environment? Not everybody's the best fit for that. And so it's just, those are some of the challenges. Who's going to be a good person-organization fit that is going to work within this model that is for that integrative focus?
All right, and just a reminder that if you do feel the need at the end of our one question, if you want to discuss something with your colleagues, please feel free to do that. We'll move on to an audience question right now. The first one is, what resources do you have in your clinics or wish to have in your clinics that assess and support spirituality? So I guess the spiritual aspect of the human. So I guess we could start with Dr. McNally, since...
Sure. So I think personally in my clinic, which I don't even think I mentioned this, but it's Northwest Functional Neurology. It's down in Lake Oswego. It's a private clinic. We're basically dealing a lot with concussions, brain injuries, like I stated before. And with that being said, there's always a psychological and spiritual component to head injuries, but even just normal physiology. I think one thing that we may be lacking, admittedly, is that we don't do a lot of psych work. But like I said, we're in the process of adding someone like that to do that, because like I said, I'm one person. I can't do everything, kind of like we've been saying. So I think I think the spiritual aspect is definitely needed to be addressed, but I think also it needs to be done by someone possibly more in your realm.
So my experience in traditional psychology is that we don't talk about religion and or spirituality with our clients, that we try to respect their beliefs, but that's not related to the mind, and that, we know that's not really an accurate perception. And a few years ago, we had a couple of our doctoral psychology students challenge us on this idea that we weren't asking about people's spiritual practices or their religious beliefs. And they developed a whole training for us and then come in and present it every year. And it's been really helpful. And some of the research they shared with us, I can't remember the number, it's 60, maybe 80% of the patients that we're seeing have some spiritual religious practice going on, and it's part of their daily lives. And here we are spending this time talking with them in their medical appointments, in yoga therapy, in a traditional mental health therapy, and we're not talking about that. So starting to integrate that in and making sure that we leave space for that, and that, well, that may not be my practice, that's okay, I'm there to serve the patient, and then working together so that we are all meeting the patient where they're at and welcoming their lifestyle and who they are and supporting them. And one thing I'm always curious about, and I think we could definitely do more of in our clinic, is what is the culture's framework or the spiritual framework around health and wellness, and are we welcoming that, right? Are we integrating that in? So are people healing through their spiritual practices, and am I supporting that as a clinician, am I supporting that as a director, so that we're making space for that, even if I have no knowledge of that, even if I don't understand it, that we make some space for that and allow that to be present.
I think that's a great question. And so oftentimes with patients, I'll ask them if they have a spiritual faith. It's sort of open, it's an open question. And then they can fill it in how they want to, because not everybody goes to a church or a temple, and maybe being outside is their church and being close to however they describe spirit or what have you. And so just asking that question, I think, can be helpful. But yeah, I think that we could do it more elegantly than that and have people who may go into that. And so one of the nice things that we can refer to the chaplains, so the chaplains that are non-denominational can come in, but also the social workers. And so having that ability to maybe go a little bit further, because as we know, Cicely Saunders, the founder of the Modern Hospice Unit, talked about total pain, for example. That was mind, body, and spirit. And so some of the aspects of pain are physical, but some are mental, emotional, and spiritual. And so how do we fully encompass and treat that whole person? Because maybe some of the angst, discomfort, pains that they're going through are derived from that spiritual realm.
So we have a questionnaire when you first established with us that asks that question and asks if you want to discuss it and if it's something that you want involved in your treatment plan. And so then we have 4 pain psychologists that are all trained in kind of spiritual training that also do a lot of that work, and then our yoga and mindfulness instructor, and then our pain psychologists also do mindfulness, and then they will bring it up with the patients who have asked to specifically address it. But we don't just address it with everyone unless the patient discloses that question that they'd like to address it. But maybe we should look at asking everyone. We just haven't to date, but it's a good thought.
I forgot to talk about my specialization is addictions and dual diagnosis, and spirituality is very important for many people in early and ongoing recovery, and the role that the higher power plays in the 12-step process, which isn't for everyone, but it is for many people around the world. And so I think that is helpful to think about, how do we bring that in and talk about that? How do we make space for that? How do we help some of the clients that are ambivalent about maybe going to community supports like 12-step and help them understand that higher power can be whatever they need it to be, and that really looking at that spirituality and that connection and the function that serves from a recovery perspective is a sense of fellowship with other people that have similar values who are also struggling with this addiction process and are focusing on being as healthy as they can be in their recovery. So I just think that's really important to think about the higher power piece and how that fits for people, and specifically for those folks that are working on giving up their addictions, that can be a really important piece in their recovery, is to have community supports like 12-step.
All right, we have another audience question. How do you make multimodal care plans affordable for the patient while still paying your practitioners what they are worth? So we'll start with Dr. Moonshine.
Well, this is a fascinating question. And I have the benefit of being a university-sponsored clinic, so I don't have to make money. And many of our providers are student clinicians, and so we don't pay them. But I am familiar. So there's that. But I am familiar with the world and have worked at other places. And I think this is a challenge with our funding streams right now. I think we're getting somewhere. But, you know, one of the things we ran into with, we're a Medicaid provider for mental health, and the Medicaid will pay for a psychiatrist or for an MD to prescribe psychiatric medication, but they won't pay for the naturopaths to do it, even though it's clearly within their scope of practice. And so we're fortunate in that we were able to bill the mental health piece and not worry about getting paid for the naturopathic piece. So we provide that for a complimentary or for pro bono for the patients. I think this is challenging, and I think it's even hard to get insurance companies to pay for both mental health and addictions treatment at the same time. So I think the money comes later, and we have had funding issues that have been really frustrating, that we could have more professions represented in our clinic if we had better funding streams.
It is definitely a challenging issue. And so is it getting better? Yes. And so one of the things that drives change is showing, it's basically answering that question is show me the money. You know, it's like telling people how it's saving them money. And so a lot of that may be downstream dollars. Maybe it's going to be we're saving $1. It's a soft dollar, so we're not really earning that. But definitely getting better with insurance billing. That helped our clinic specifically, was just being more accurate with how we were billing. And it's like, so we were undercoding, and then we're more appropriately coding right now, and that has changed things for us. And so we're much more viable now to pay people what they're worth, for sure. But it is one of those ever migrating lines, because insurance companies change their lines of coverage all the time, and we're dealing with a change right now for some of the things. But I think as we see the data coming out for support, that I think we'll see more and more viability that way too, that just validates.
So I'm kind of in Dr. Moonshine's situation where I'm a little lucky because I'm in a salaried position, right, in a big academic hospital that supports all of its clinics when they can't meet their bottom line. Although we now are a self-standing entity, so we're even separate our budget from the anesthesiology department budget. So how we've done it, and this is kind of interesting, is Medicaid across the state is 25% of our entire state of Oregon is on Medicaid. And 50% of our rural areas are Medicaid. And private practices don't take a lot of Medicaid patients. So we are one of the only pain centers in the state that take Medicaid. And so by having all of that volume, because we are the only choice for a lot of people, that volume has allowed us to make enough revenue to pay our massage therapists and our naturopaths and our acupuncturists appropriate salaries. And how we found those salaries, also very challenging, right? Because when you get credentialed at OHSU, they were like, we don't know what to pay massage therapists or acupuncturists. So we just took a survey nationally of all of the different acupuncturist salaries and kind of found a median and then went a little bit above that. And that's what we did. And it's kind of been hard for naturopathic too to figure that out. But then we use our volume on the MD end of seeing all those office visits churning through that generates extra revenue to cover some of the costs. But they cover themselves. They're so popular. I would say all of our providers, other than the MDs and APPs, are actually more popular than the MDs and APPs, and so they actually make plenty of money and definitely cover their own cost. So that's kind of how we've done it, by volume. Keeps you busy, but.
I think I can offer a little bit different of a perspective just because I'm in a private clinic versus a hospital or school system. And I think it's interesting because, like, our clinic, we don't take private insurance. It's cash, or we do PIP claims. You can't technically not take Medicare patients, but you can be non-par, and that's a different conversation. But I think what it comes down to is choosing what's the most necessary for the patient, because you can do the shotgun approach where you do, you know, every single thing under the sun, and of course it's going to cost them a fortune. But I think the thing is just picking the most effective approach for that patient to get them better. Now, as far as like pay scale, since I know most people are students here, at least like in my clinic, what we can set up is, and we'll get into like legal stuff later, I think, but you can do kind of almost like a bonus structure as far as like revenue generation from a patient too. So there's different ways to kind of do performance-based pay as well.
All right, great job. Okay, we'll move on with some of the questions that we have given before. Next question. What is the most unique thing about running an integrative medical clinic when compared to a traditional medical model role? So, Dr. Chandler?
Well, I think one of the most unique things is really stepping back and looking at that whole person-centered care, and so that individualized medicine. And that's really one of the most unique things as compared to sort of a traditional medical clinic. You know, for example, I just had lunch with Melanie Henriksen, former student dean at NUNM, and she was telling me how at Kaiser, you know, she sees a patient, but the patient maybe complains about she's doing midwifery, so it's a lot of PAPs and et cetera, sort of fertility treatments. And so, but they may complain about digestive issues, or maybe they have earache. And so she's not really allowed in that clinic to look at the ear or go further into what could that digestive issue be, which is frustrating for her. But in our model, it's like we don't have to worry about that. It's like we can really go wherever they go and treat accordingly. And so that's one of the benefits as compared to a traditional medical clinic, is really the individualized approach.
Yeah, I would agree with that. And our other difficult thing was figuring out a workflow. So our providers all worked great. So we were lucky we didn't suffer through a lot of the ego thing. Everyone in my clinic goes by first names, and we all just get along. We all sit together and work in the same room and chart in the same room when we're done seeing our patients. But our problem was the workflows, because our staff was just like, we don't know where the patient's going, where they're at, what the next plan is in the care. So it's been a lot of workflow issues, because our PAS, you know, now they get phone calls and people say, I want to see your Rolfing. What is Rolfing? And, you know, the PS will be like, what's a Rolfer? How do we explain this? Right? Because it's very different than just saying you're seeing a medical doctor and you're going to have a medical office visit. So we've had to do a lot of training and developing workflows to keep the paperwork separate, the billing all legal and authorized, and kind of stuff like that. It's just been the nature of going from very small to very big very quickly. And some of that isn't even the nature of integrative medicine, but that would happen in any clinic if you went from small to big quickly. So.
Yeah, I think going along with like what Dr. Chandler said and what I kind of touched on earlier, it's all about a whole body approach and all about interdependent systems rather than independent systems. So I think, you know, you've probably seen stats that America spends the most money in the world on healthcare, yet we're not one of the healthiest countries. But what I think is our traditional medical system is amazing at emergency care and keeping people alive, but we're not good at keeping people healthy. And I think the issue is that we're taught, and this is completely important and crucial, to check out for red flags and know when you need to have an emergency situation or get imaging or something like that, so you can rule out like a tumor or cancer or brain bleed or, you know, something else systemic. But I think the big issue is that a lot of people don't necessarily divulge the difference between pathology and abnormal physiology. So there's a huge difference. I mean, we have patients that come to us that have an MRI and they don't have a tumor or a CT and they don't have a brain bleed, but they're dizzy 24/7. And we'll put them through like extensive balance testing and vestibular, like head impulse testing to check their vestibular reflexes, and we see a huge deficiency in one side or the other. So we can come up with like an exercise plan, and that helps it when their, you know, primary care or, you know, doctor that saw them at the hospital told them, you'll be fine. Like there's obvious physiological abnormalities rather than pathology.
I think one of the big benefits of having an integrative clinic is that there's a lot more creativity. I think from the conventional medical model, there's structures in how that all works in, you know, outpatient settings and hospital ER settings. But with integrative care, we can sort of do what we want because there are a variety of different options, and there's lots of things that we haven't tried yet. So at our clinic, we're considered a behavioral health home, in that we are primarily psychology and mental health, and then we've added in the naturopaths, occupational therapy, and physical therapy, and are starting to do our team-based care that way. And because we are, I think, one, it's super collaborative, and when you have the right people on the team that are open to that, you have great conversations and everyone learns from it. It's much more egalitarian and there's less of a power structure, and I appreciate that a whole lot more. And then from a mental health perspective, and I have a degree in clinical pharmacology and could be a prescribing psychologist if and when we license in this state. And conventional medicine responds to mental health with medications, psychiatric medications, which may be helpful but not always, with enormous side effects. And so being an integrative care clinic and having that creativity is that we've been able to offer the patients at their choice a variety of other natural options that don't include psychiatric meds or may include psychiatric meds at a much lower dose. And so that has really been eye-opening and allowing a lot of our patients to say, you know, when I went to another Medicaid clinic, the only option I had was to take psychiatric meds. So I really appreciate having that creativity and being able to work together and often finding solutions that I would, of course, never have thought of on my own.
All right. Next question. What would be the most necessary interview question that might address the specific needs of an integrative medical clinic when hiring a new team member? So, Dr. Mauer?
So we went through this a bunch because we've hired a bunch of people. So what we did was we said the most important for anyone we hired was that they're a team player. Like one person on the team can't think that they by themselves and whatever their practice is can cure everything, right? It's definitely a team approach. And just like we were saying, it's much more fun and much more creative and you have more options for your patients. So we looked for people that were like, I want to be part of a team. I know that my treatment will contribute, but it's not going to be the sole treatment that makes them better. And that's exactly what we found. Not one person in our clinic makes the patient better. It really takes everyone. And our patients do like the one-stop shopping. And we're moving to a model now where for your condition, you come in and get everything you need for that condition on that one day. So if it's knee pain and you need a denervation and you need acupuncture prior to your surgery and you need mindfulness to get you through the general anesthetic, you get that all together. But I think it's a team approach, open-mindedness, and people who are willing to think outside the box is what we look for.
Personally, I just ask if they're a Dallas Cowboys fan because I'm from Philadelphia, so if they like the Cowboys, they're out. No, I'm just kidding. But I think going back to even like what we were talking about earlier, which is health. I mean, I would love to just hear the answer to someone's subjective response to what is health. What's the definition of health? Because I think that can teach you a lot about that person and what they think is the desired outcome for your patients.
I would say curiosity is important, having more of an egalitarian collaborative mindset, and I kind of want to know a little bit about bias. And we all have bias, we all have opinions about things, and that's okay, but am I open to say this is my bias and maybe that's not accurate, or maybe I can learn a new way of doing that? And that's been a personal transformation in our integrated care clinic for me, to realize that I had all these pre-existing biases that were not based in reality at all. So I want to know if people can work through that process and be collaborative and be respectful. And we don't have to be friends, we don't have to, do things outside of work, but can we respect each other, and can we be open to other people's viewpoints?
Those are all good. I like those. Our questions incorporate some of that too. And so when we're interviewing, we do have a series of questions, but we are trying to figure out, how do they view health, but also how they communicate and how do they react under pressure, because, when the schedule shifts and you have a lot of moving parts, there's going to be impacts on all that. So, but a big question for me is also critical thinking. And so how are the people critically thinking with regards to what they're faced with? And so do they have that ability to sort of maintain that open mindset and think about all the potential interactions, implications of things, and to keep their viewpoint broad? And so when I'm talking with somebody, that's one of the things that I'm trying to cue in, is what's their level or ability to critically think, and almost more importantly is, are they going to have fun? So that's a key thing for me. If you're not having fun, then that's not going to be fun for everybody else.
All right, we'll move on to an audience question. How can we grow the integrative medical movement to include more sites or integrative clinics across the country? So, Dr. McNally?
Well, I think it's kind of a grassroots movement, right? Because even 10, 20 years ago, there wasn't this collaborative effort between different types of professions, right? So I think the biggest thing is to continue things like this. I mean, like, there was no club like this where I was at in Atlanta, and there's tons of medical schools of all types. So I think, continuing to get heads together, to combine all this. And then obviously, I mean, like some of us have said, like the hurdle on some of that is just space. So it's tough to build new clinics. So I think the proper way to go about it is just further integration and adding more professionals to existing clinics.
I think it's a lot about relationships at a lot of different levels. So sort of on the lowest level, maybe not the lowest level, but it's sort of the grassroots level of building relationships within our clinics, within other clinics, reaching across the aisle and working with other professionals. And then I think moving up advocacy with politicians, with legislatures, with insurance companies, and using the data that we have to show that this is working as well as, and if not better than the conventional medical model, and to show that we may be serving people that aren't going to be served well in that conventional model, so that there's even more success between having both integrative and conventional medicine.
All right. So going through my MPA, one of the things that we talked about is that most change is incremental. And so it's very rare to have a non-incremental change. And so I think part of what you're seeing is just over time that we see this change happening and it's increasing. And so when you look at institutions around the United States, hospitals, clinics would add integrative medicine, but because the public was demanding it, that's one of the big drivers is public demand. I mean, we're not at Providence if it wasn't for public demand. One of the key reasons why institutions drop integrative medicine is because of the cost. It's not considered a star in the hospital system. Stars would be like surgery, imaging, things that make you a lot of money. The dogs are the ones that don't make you a lot of money. The ER is a dog, but it feeds the hospital. That's why we have them. So when you think about some of the reasons why institutions drop integrative medicine is because they don't make money. So how do we fix that? We have experiences here, and like we're doing is doing that. Where are we showing that we're saving money? It's like the more that we can tie in cost savings, the data, you're going to see more hospitals, institutions, clinics offering this, realizing that it may not make them money, but we're actually impacting healthcare in the short term, but also in the long term. So we're saving a downturn dollar. So maybe we're stopping somebody from being diabetic, or maybe developing cancer, or developing any issue. And so I think that when you look at just where we're going over time, you're seeing that that's going to change, and we're getting more data to validate it, and that's going to drive further change. So it's sort of a self-feeding cycle. I think that's it.
I would say the same thing. So what we're doing is trying to develop a lot of research. So we're, as I mentioned earlier, we're partnering with Duke to show evidence base in this model that all the complementary medicine and integrative medicine is making our patients better and saving cost and not harmful. And we're writing on the public forum right now that the government's all about safety, right, with this whole opioid issue, at least in my field of pain management. So we're using the safety factor as a big bone, because while we may not have evidence for gabapentin or naturopath or massage or rolfing, and some of those things don't have the evidence we want, we know they're not going to hurt people, right? And we know opioids hurt people. So at least we're adding in things that aren't as harmful. And we know epidural steroids and steroid medication aren't good for people. We have that data, and that's strong data. So we're trying to show with studies that we're bringing in therapies that aren't harmful and that actually are showing benefit. And I think it's going to come down to data, because that's what the insurance companies look at now, right? It's not good enough anymore to have a physician's note say, oh, the patient's getting better, they're happy. You have to have the data behind it. And we're moving to pay for performance, which means insurances aren't going to pay for my bill of $20 and the naturopath's bill of $10 and the acupuncturist's bill of $5. They're going to pay a lump sum to my clinic of $80 or whatever that added to, and we can divide up that $80 among acupuncture, rolfing, massage, mindfulness, yoga, chiropractic to get the patient better. So we're going to need those studies to demonstrate that. So I think it's going to be research and collaborations like this, like things like this.
If I could add one more thing, I think one of the important things is actually Epic or some electronic medical records. And so with that, we have the tremendous ability to do a deeper dive into what are we doing? Who are the patients that are getting this integrative care versus those not? How do we do sort of controlled studies? Who's the control group? Who's the treatment group? And so having some sort of electronic medical records in your charting database will further that movement towards getting the data and being able to do a deeper dive. So to give you an example, we did a study at Providence to find out what's the impact on palliative care with regards to cost savings. What they found out is that it saved the institution $12,000 per visit for palliative care. So if we can start tying dollars to that, then we're going to the insurance companies are going to be like, maybe we should start doing this.
All right, next question. Are there any specific legal issues that you might confront in an integrative medical clinic as opposed to a traditional medical clinic? So we'll go with Dr. Moon.
I think it's me. So this is a small thing, but a difference in the world of psychology versus everyone else is that I have the discretion to not report child abuse. So if I think that if I'm working with and I rarely would I do this because I feel like we always have to ask for the kids, but in this state, we psychologists are privileged in the same ways that lawyers and priests are privileged around abuse reporting. Not other therapists, just psychologists. It's an odd little law. But if I think it does more psychological damage to report the abuse than not, I can do that. But if I'm in a primary care setting, I don't have that option. So that's one thing for us to be thoughtful about. From my hospital, I can't think of any difference legally, but maybe you guys have a better answer.
No, I haven't really come across anything that is legally inhibitive for our practice either.
Yeah, I haven't come across anything legally. I've come across like the standards of care OHSU does because of Joint Commission and stuff that's been difficult for our providers we brought in because like I told our massage therapist, I said, you have to document in your note you wash your hands. And they're like, why do we have to document that? We always wash our hands. I'm like, I know we all wash our hands, but we have to say it at OHSU in a note that we wash our hands. So it's stuff like that that we've struggled with, more of the charting, you know, and our chiropractors at OHSU have to document past medical history, like we all do anyway, but there's some little extra things. And I think that's more tied to OHSU and a federally and state funded institution than it is to anything legal.
Yeah, I think the biggest thing is just to stay in your lane as far as your you know, the laws in your state. And there's differences between states too. For example, like for me coming here, I had to take extra minor surgery and OBGYN and proctology boards because chiropractors are allowed to perform those services here. Not that I do it, but you had to take the boards just to get licensed, right? So, and then there's other things that can come about, which is a national law as far as like kickbacks. Like you're not allowed to receive money from referring someone in your own clinic or in any clinic. So it's not necessarily a different law. But the other thing that that you can get into are, I forget what the law is, but I forget what the name of it is right now off the top of my head. But there's some states that prohibit specific financial agreements in a clinic, whereas hold on a second, I actually have it here. Fee splitting. So say under me, I'm technically an associate at my office, and let's say I make 50% of a visit from a patient. I'm not legally allowed to say a visit's $100. We're not legally allowed to just say, all right, I get 50, you get 50, because then it kind of looks like a kickback, right? So there's ways that you have to legally structure your contract to I mean, not even get around that, but just to comply legally. So, you know, stay legal, stay in your lane.
I will say that there's a difference in how psychology works versus other medical professionals is that we tend, maybe in yoga therapy we do this, but in almost all other therapy, we do not physically touch the patient. And we're have very clear boundaries about what we're allowed to do and not have relationships with them outside of work. And so we had a situation with one of our psychology students who was drunk, texted one of his psychotherapy clients, wanted to, you know, arrange a hookup, and he wound up being removed from our program. But as we went through the hearing process in the College of Health Professions, they thought, well, that wasn't great, but it wasn't terrible. But in the psychology world, that's the worst thing we can do, is try and cross the boundary and become somehow physically engaged. And that's completely different, not so much in the personal relationship, but you guys are laying hands on, and you are very personal. I have psychology students that are at NUNM on their rotations, and when a gynecological appointment comes up, the psychology students step out because we shouldn't be involved in that up close and personal with our patients, which is different from those of you that are on the more medical side.
And you also have to realize that you're in charge and liable for your assistants also. So for example, like chiropractic assistants, laws change constantly. Like, they used to be able to only do massage, but now chiropractic assistants can perform like myofascial work, like trigger point therapy, like manual therapy, not injections, but things like that. So you also have to make sure that you're on top of your staff and assistants as well.
So we have 4 minutes left, meaning we don't have time for another question. Is there anything that any of you want to address specifically before closing this panel? And if not, I can ask you a question. You're just going to have to go really fast. Okay, go fast. All right. When running an integrative clinic, what is the most efficient way that, I'm kidding. Okay, when running an integrative clinic, what is the most efficient way you've found to whittle down how many clinicians to one new patient? So, Dr. Chandler, it is your turn. Sorry.
We don't limit either, I was going to say. So here's what we do is we go into, and I don't know if this is the best model, I'm just going to tell you what we do. We go into the visit and we tell a patient everything on our plate that we offer. And they pick and choose almost from a menu what they want to try. Because in our book, we can't predict what's going to work. Acupuncture might work for one person and chiropractic for another, and mindfulness for another. And so we let them pick, then we run the insurance, and then we come back to them and say, this is what's covered, no pay, this is what's a self-pay, and we try to make our self-pays very compatible with what the community self-charges, and then we just let our patients pick, and we don't limit.
Yeah, just so as far as a private clinic like mine, the patients come and they call and they basically get assigned to a doctor based on who they choose. So they come and they choose to either see me or Dr. Zielinski, who I work with. And based on there, like one person will do the exam, and what sometimes happens is we'll end up sharing patients a little bit if we feel like one of us has a little bit more of a specialty in one area or not. So it usually needs some hierarchy as far as like one person does the initial exam, and then if they feel that someone else in the office can benefit them efficiently, then you can share.
I think patient choice should drive it. And then the other place that we've had success with this is in our interprofessional team meetings that we have before each of the naturopathic shifts, is that we're talking about the patients, and someone might say, well, have you considered an occupational therapy evaluation? Maybe talk to the patient about that. Have you talked with the psychotherapy client about there are natural alternatives, they don't have to take psychiatric meds? And so our own education about each other's scope of practice and knowing when to say, well, I know of these alternatives. Some of them are here, some of them are in the community. What are you interested in? And then I think, helping the patients be their own best advocate and do their own research, on the internet and learn about things and then decide what's really going to be helpful for them.
I'll add something. Because patients come to see us for variable reasons. Maybe they're coming for massage, maybe they're coming for acupuncture or naturopathic. But then the nice thing about integrative medicine is to say, if they came to see me, it's like, have you thought about massage? Or have you thought about chiropractic? And it goes both ways. The massage therapist will be like, you're having these issues. Have you thought about seeing this provider? And so that's really a big piece of it. They come for various reasons, but then it's our job to say, okay, how could you do better from what I know? Maybe somebody else is going to do something that I think may help you, and let's find out what that is.
All right, I apologize if we could not get to your question today, although I guess I'm not speaking on behalf of you guys.